Welcome everybody. Today it's SEVA VentRounds, December 9, 2025. And we're gonna have a case and which the question is no diaphragm, question mark, and winning is the overall topic. There is no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion, and it does not represent the Cleveland Clinic. I just realized something, Rob. This is your last official VentRounds as an employee of the Cleveland Clinic. The next one, you don't need to do disclosures, I guess, or maybe you do.
I think it's always good to do disclosures if I'm going to show my face, right?
Yeah. All righty. Well, that serves for everybody just to know that our dear friend and mentor, partner, Rob, is returning at the end of the year, and we thank him for everything that he has done. But here are his disclosures and my disclosures too. So thank you, Rob. All righty. Ground rules: just keep your microphone muted so we don't hear the cat. The moderator may call you upon members of the audience to comment. If you want to comment, use the chat function, or you can unmute yourself at that point and make any comments that you want. There's CME and CRC for all of the RTs and the physicians from the Cleveland Clinic that are joining us today. Remember to fill out your evaluation. And so the key SEVA knowledge, and in this case, there's no waveform, but I would highlight this paper by Laggy and Tobin in the Blue Journal in 2003. And just for the sake of overall knowledge, I will point you to this image, in which you have the brain and the motor cortex. And the motor cortex, there is a connection that it's called the corticospinal tract, and that corticospinal tract goes all the way down to the spinal, and then there is where the phrenic nerve tract will come out and then will innervate the diaphragm as well as other respiratory muscles. That's important for you to be aware. And so this tract, the corticospinal tract, essentially is the one that you right now take a deep breath, and it's the cortical or volitional part of your breath. But there's another tract which is coming from the medulla area, in which you have your respiratory neurons, and there you have your respiratory centers, which are sending intermittent signals mediated by a series of chemo and mechanoreceptors, sending signals for the same neurons to actually trigger those breaths, and that's the bulbospinal tract. So we always have this going through all the way to the diaphragm. Now, it's important to know that if I do a section of the spine up here at the level of the medulla or the high cervical spine, the nerve that innervates the diaphragm will remain intact. All right, and so that's important for you to know, which is different than if I do a surgery and I cut the phrenic nerve, and then under those circumstances, the muscle will not get any signal. And if you cut the bulbospinal tract or the corticospinal tract at the level of the high cervical spine, then the nerve still exists, but it's not getting the signal from anywhere. And that's where the thought of putting diaphragm pacers in the phrenic nerve goes along, because then the nerve is still intact and you can pace it. You can give it an electrical signal and pace the diaphragm. Rob, any comments?
Nope.
Yeah, Ariel, and then there's the muscle down here and the nerve. Yeah. All righty. So let's talk a little bit about this waveform. So here you have the first question for you is, what's the tag for this mode? And then we'll go over the screen in detail, but I want to start by what's the tag, just by looking at the settings as well as the mode. This is a servo U ventilator for all of you that have not seen this screen before. Have no fear. There you go. Fernando putting it in. Let's see if anybody else. Very good, Trish. So absolutely, this is pressure control, CSB. So all breaths are spontaneous. We're controlling the pressure, and we can see that immediately just by looking at the flow. It looks like a sine waveform. And then it's S, meaning the set point. You guys put everything there. And yeah, actually, Ariel, you're absolutely right that this is where an area that we rarely talk here on BenRounds, but I will put them for you today, is that we have used brackets to define the subtype or variety, if you may, variety of PCCSBS, because there's many varieties of PCCSBS. So in this case, it's what the variety is just CPAP, and that has to do because you can see that the pressure support was set at 0. So this patient is essentially just breathing at the level of PEEP or CPAP, continuous positive airway pressure. Rob, can you talk a little bit why we did this?
Well, I think you mentioned it. When we classify all these different modes, we found that we had a large variety of modes that had PCCSVS. And there were some that had PCCSVR as well. There was a number of those. So they were very different. So for example, pressure support is very different than CPAP because one has assistance and one does not. NAVA is very different than PAV, right? But they're still both PCCSVR. So we wanted to preserve the fact that they're different without using the name of the mode. So NAVA would be PCCSVR in brackets EDI, because that's the signal that it uses in the targeting scheme. And there are a number of little ones like that where we have these brackets. The brackets is what we call the variation of the mode, just like there's variations of roses, red ones versus yellow ones or something. And we only use it when there's a lot of tags that are otherwise identical, but you want to distinguish very different targeting schemes or very different behaviors in some way.
And do remember, and I'm going to put it here, that the idea of these tags talks about how the mode is supposed to work. Ventilator performance can be different, and there's all these other items. So that doesn't modify, Ariel, just, and it's not undercover levels of pressure support, it's just an amount of pressure support to maintain the pressure in the airway, which leads to a little bit more of assistance. So I'm not gonna go into that at this time for now, but we can come back to discuss it. So let me orient you to the screen for those of you that have not seen this screen before. And it's an important thing for every ventilator that you have used before. The first one is where your mode name is. And in this case, you can see that it says pressure support CPAP, and then these little arrows. And sometimes people misunderstand this as a auto mode because it essentially it's saying that it will go back into pressure control back and forth, but that's a backup. And you can see it down here on the settings all the way on the bottom. And that's an alarm situation in which the patient goes into backup, the system alarms, and that goes in. It doesn't mean that it's IMB. The second part that I would focus you is that you can see that in the first three boxes in yellow are pressure measurements, the peak pressure, the mean airway pressure, and the PEEP. And you can see actually the limits for alarms that have been placed. So here it's at 40. Here the limits for PEEP is 15 and 2. Then the respiratory rate and the inspiratory time to total cycle time ratio, and then the oxygen concentration. Then here in blue, relating to the tidal volume, you have the minute ventilation, the tidal volume per predicted body weight, which we have not entered the tidal volume of the patient yet. And then you have the inspiratory and expiratory tidal volume. And then on the bottom in pink, you have the EDI, the electrical activity of the diaphragm. And this is described in the literature also as EADI. And there's the peak, which is the maximum. that a given waveform generates, and the minimum, which obviously is the lowest that you have at that period of time. And the amount of time that this is reporting on is not entirely clear to me, but it's that those are the values that you have. And then you have here the dynamic compliance with a big asterisk, which is telling you this value is including everything, and it's not to be trusted as a compliance per se. It includes also the resistive load, the PMOS, and the tidal volume. It's just a messy number when there's PMOS. Rob?
Just a quick note, when you see EADI in the literature, it means electrical activity. When it's E all by itself, that stands for like electromotive force or voltage. That comes from electronics. Also that TI over T tote, we never talked about that before, but that's the percentage of the total cycle time devoted to inspiration, or the inspiratory time. And it's also called duty cycle. You see that in the literature.
And so, Rob, this is useful because now you know that of the total time that this patient is taking a breath, 30% is devoted to inspiration. How is this different than the I/E ratio that gets displayed on the ventilators? Can you comment a little bit on that?
Well, there's a mathematical equation that relates those two things together. They are not the same thing, because the I/E ratio is the inspiratory time to the expiratory time, whereas this is more like the inspiratory time to the inspiratory time plus the expiratory time. So they're two different numbers. They mean two different things.
Very good. Thank you, Rob. So now that you have seen this, and I thought that it would be good for you to have this as a background, what do you think is the load? Elastic, resistive during inspiration? Let's start with inspiration, or PMOS. All right. Very good. So PMOS, there's definitely PMOS. Excellent. So, and I really like, thank you, Ariel, for putting that. You cannot read if it's elastic or resistive. So it's the dominant feature is PMOS, and PMOS hides the elastance and the resistance. So great point. Now, during exhalation, elastic, resistive, or PMOS? It's a tricky one, right? It's hard to really have a beautiful waveform, because you see there's this amputation of the peak expiratory flow, which you would expect to see. So you would expect to see something like this, which tells me that there was still some effort from the patient occurring, but the ventilator cycled, and so that's missing. And then you see this continuous decay here, but there's a lot of noise there. There's this up and downs, and sometimes when I see too much noise, I like to come and see my volume waveform to see if I'm seeing a lot of movement or not. And you can see here the decay, and the decay is relatively fast. It's within 1 second. So this patient has a dominant elastic load, and perhaps some PMOS. I'm not entirely sure. We'll see. But there's a lot of noise in this waveform. You see how those oscillations are? Yeah, good questions. And then, so that's the PMOS. Very good. Sorry, PMOS.
A minor comment here, Eduardo.
Yes.
If you look up on the pressure waveform,
yes,
you see that the pressure spikes just before the flow goes towards zero. So
yes,
what if the patient was panting? They were making an expiratory maneuver, and that the peak flow wasn't chopped off, it was just accelerated, pushed more negative by the expiratory force. How can you tell the difference?
yeah, you couldn't. I think that it can go from, this is an artifact, but the difference here, Rob, that I would say that why this would not be active expiratory muscles, that why I think that this is not active expiratory muscles, and just the fact that the patient PMOS is going down, is because you amputated the tip. Now, if the patient is exhaling actively, this could look the same. So
Mhm. Yeah.
it's hard to say, but you can see the peak here and the last breath, and how there's a peak down here. So I
Mhm.
think that
Mhm.
this may be, it's without putting my hand on the patient, it would
Yeah.
be hard for me to say. So I will, and this is a good public announcement. I wish Waveforms would tell us 100%. It tells you a lot. But if you don't put the hand on the patient and you don't look at the patient, you're likely to make an error. So if you're at the bedside, look at it. And I can tell you, you're going to hear more about the story about this patient later on. And so Ariel asked a question about the EDI, but I would highlight to the team. So you're seeing, before we go to the EDI, Ariel, I want to just ask the team, do you see any PV discordance? How's the trigger? Normal, early, late, false, or failed? So the trigger for this patient, you can see it's flow. The white color is right here. And there's some features that may signal towards, there's not enough information on this waveform that triggers this one, but it seems to cross over. Perhaps just looking at where the pressure dropped, it's before the one, this tick mark. So I think that the team most probably started right here. So there is some delay on the start, but this one looks pretty decent. This one looks pretty decent. So I would say that's probably normal. Probably normal. Not particularly late. I would like to see more, but I think normal. Rob,
I agree. It's hard to
uh,
tell.
during inspiration, is there assistance over or under assistance? Assistance, over assistance, under assistance. Oh. So there's evidence of the patient doing effort, right? So the ventilator is not delivering any or very little support, very little support. So in this case, the patient is doing the majority of all the work is done to the patient. Now, remember that the definition of under assistance is when this is unintentional. And so in this case, we made the patient do this amount of work. So it's a clinical statement. Sometimes, remember, under assistance or over assistance is when it's discordant with the goal that you have chosen. In this case, this was the goal that we put for the patient, but technically this patient is under assisted. Uh, so without a doubt, the patient is under assisted, but do remember that this is context dependent, goal dependent, to put it there. And in this case, it would be just a normal state. This is intentional, so it's not pathological. Cycle, I mean, we saw the little beaks up here. Uh, Rob, what do you think? Normal, early, or late?
I think I think it's normal given probably the way that the pressure support was set up. I don't see any evidence of the patient forcefully trying to exhale, which would be, a late cycling. You can't get early cycling, I don't think. Well, you can't get early cycling with pressure support, but I don't, possibly, if you think that that was a chopped off peak expiratory flow, you might argue that that's an early cycle. You know.
And in a way, I like to draw this line for you guys to just say, I mean, the goal of this mode is essentially CPAP, right? So we have turned off the the pressure. So the ventilator, as we have said, and this is applies to all, this is not a criticism of this ventilator in particular, but in general, they're mediocre at controlling pressure. So you can see that the drop below is a marker on CPAP that the patient is doing effort, and it should be maintained by the ventilator. And whatever is above is the ventilator trying to maintain the pressure, and then the patient is switching to expiration by either relaxation of the respiratory muscles or by switching to active exhalation, and the ventilator is trying to keep the pressure at a given level, and whatever is above is essentially an artifact in ability of the device to control the pressure. Rob?
Yeah, and just to point out something that if the patient, even if the patient was making very little effort, some ventilators will give you 2 or 3 centimeters of pressure support, even though it says 0.
Correct.
And they do that because of what you just saw. You know, it's unavoidable that the pressure drops a little bit on inspiration. So the engineers try to make up a little teeny bit of the work to trigger.
And this is meaningful. I mean, you demonstrated that on that paper with Samir on how there is, regardless that you put them 0 over 0, some amount of support that comes from the ventilator, and that's what Ariel was highlighting.
Right.
Yeah. All righty. So now let's talk a little bit about this electrical activity of the diaphragm, and this is right now here as a marker of electrical activity of the diaphragm, and I can tell you that so what observations do you have about this electrical activity of the diaphragm, team?
Can you talk about what those dotted white lines mean?
I will.
Okay.
All right, so I see that it's too low and erratic. Any other comments? All righty, so normally, so what you see here, team, is a catheter that is placed in the diaphragm and through the esophagus, and it goes through the crew of the diaphragm. So the diaphragm wraps around the esophagus and then inserts itself in the spine, and it does that to anchor, and it's a part that it's very rich on muscle fibers. And the catheter, which is highlighted here with these black lines, is essentially has all these little black lines, which are electrodes. And when you insert the catheter, it will highlight in pink when the activity of the diaphragm is seen. But there's a screen that I should have put here that will show you an EKG that tells you that you're behind the diaphragm. And normally what I would expect to see is that every time the patient breathes, there should be a rise on the electrical activity of the diaphragm, something like this, just to show. And instead of that, we're seeing this flat statement. So what can that mean? Why is there, clearly you all saw that there's evidence of PMOS, but the electrical activity of the diaphragm, as Ariel said, is very low. I mean, normally we should be seeing peaks 5, 10, 15 with this level of activity. And instead of that, we're seeing a baseline with no activity, essentially. I mean, 1 microvolt is no microvolt. Usually this device, just so that you get, when you're on NAVA, you need 0.5 to trigger. So we're seeing very little. So what are the potential hypotheses of why we don't see any peaks that go with this? All right, so one is that there is failed triggers. So, but that's unlikely because you can see that there is clear evidence of PMOS throughout. So failed triggers do not. Weak diaphragms can be weak. Diaphragms can be weak, but if the electrical system is there, then you should have an EMG signal. And that's actually one of the concepts of high drive and low PMOS, also, or POC, or electromechanical uncoupling, in which there is a big signal, but there is no muscle contraction. What else? What other etiologies can you think of why we don't have a good signal?
Are you assuming that the catheter is in the right place?
Excellent. So that's one of the issues, is that you place the catheter and you get the EKG signal, and then you loop around and it goes up. And we've seen that a number of times with the NG tubes and others, is that you place, so absolutely, Fernando, is that you place it, it loops around and it goes up. And so then you miss the signal for the crew. So you avoid that. The other one is that obviously phrenic nerve, problem in the phrenic nerve is a good one, Fernando. That's another potential etiology. And Ariel also mentioned, well, maybe the patient is doing breathing with other muscles, not with the diaphragm. So is there any maneuver that you would like to do for this patient? An inspiratory, I didn't do an inspiratory pause on this one, but I did an expiratory pause. Yeah. So let me show you the expiratory pause. So here's the expiratory pause, and what you see is the electrical activity of the diaphragm on the bottom, right here. And then you have the tidal volume that the patient is generating, which is, and then the flow, and then the pause, and you can see that they try to trigger, and so the pause get activated, so there's no flow. You're gonna see it move up and down, but that it's not relevant, it's very little. And you can see the pressure in the airway goes down, and it goes from the baseline PEEP, which was 8, and it drops to close to -1. So the patient generated around, I believe it was 10 centimeters of water of PEOC. Just to make it easy, that would be around 7.5 centimeters of water of estimated PMOS. And we have done other of these calculations in the past for you to calculate, but this is for you to know that it's 75% of the POC. But you can see what this patient generated. So, and is there any change on the diaphragm? No, nothing. Yeah, this is all accessory muscles doing the work of breathing for this patient. So this is another tracing, and I put this tracing. This is a tracing of this patient, and I have not seen this, and I have to ask the makers of the device. This patient had a diaphragm pacer, muscle implantation of the diaphragm pacer, and we activated it while the NAVA catheter was in there to see how it looked, and we would get these boxes of signals. So I guess that it kind of normalizes or neutralizes, and it just shows you that it's there. But interesting is that in this case, for this patient, there was no change on the airway pressure or the tidal volumes when the diaphragm stimulator was acting. And so, and this happened with expiratory pauses and without expiratory pauses. It became very evident that there was no transmission at all of or this diaphragm pacer was not generating significant, let's put it that way, amount of diaphragm contraction on this given patient. And so, so I'm going to pause there. Rob, comments?
I've never seen anything like that. It looks looks like the diaphragmatic pacer was swamping the signal to the EDI, and it wasn't able to pick up any contraction. But you said there wasn't any contraction when there was a stimulation. Is that because the pacer wasn't properly inserted, or what?
Well, that's a great question. So, what are the potential hypotheses? The potential hypotheses here are: A, the diaphragm pacer is not on the right place. B, the pacer is so it's not on the right place, or the phrenic nerve is dead, or the diaphragm is dead. And when the phrenic nerve dies after you cut it, at the beginning there's going to be ability to stimulate it, but with time it degenerates, and then you lose the ability to stimulate that muscle. And so that could be the cause, that there was phrenic section or disease that stopped the conduction, and that's where you are now. So either or. In this case, because we see the signal, I think it's because the phrenic nerve on this patient got severe. The patient had a very complex cardiothoracic surgery, and was deemed it was failure to wean from the ventilator, so a pacer was placed elsewhere, and then we received the patient, and we wanted to see where was the diaphragm on all of this, and so we did this analysis, and this is what turned out. The patient is now breathing unassisted, without the ventilator, weaned off the ventilator, only breathing with accessory muscles, which is pretty impressive. All righty. So questions from the audience? So the key findings, we went over, the tag, and essentially we talked about the variety, and we talked that we placed the variety, and you're going to see that on the bend mode map and your tools, which we put the variety as CPAP in this case because there was no pressure support. The other thing that we reviewed was the electrical activity of the diaphragm as presented by the NAVA, and we discussed, troubleshooted why the signal could not be there. And we talked about catheter misplacement with the patient, and that being a cause of what's going on, or in this case, a phrenic nerve injury. And so we talked about phrenic nerve by itself. We analyzed the POC, and we reviewed the concept of POC as well as the estimated PMOS. And finally, what else did we do, Rob, that is worthwhile?
Well, one thing I want to point out is that PMOS is a sort of general global measurement. It doesn't mean that the diaphragm's working. It simply means that there's pressure generated by ventilatory muscles. And so we have a bunch of those. It's just like esophageal pressure is a general global pressure across the whole lungs. So don't get confused into thinking the PMOS only means the diaphragm.
Excellent. And do remember, hand on the chest when assessing your patients or watching them carefully. So wonderful input. Here is the CME for CCF caregivers with the code, as well as the CRC for the RTs. Remember, we are on episode 101. Oh no, 102. This is 102. There's all of the other episodes are on YouTube, and you can see them. And then do not forget to register for the SEVA program next year. The SEVA Summit, there's still slots. They're going fast. We're, I think, I think we're like 65, 70% of the slots taken. So please register. Here's the link. Register for the SEVA Summit, and we look forward to seeing you.